Hi, this is Brian Kim. I'm going to share with you this case of a patient who had an IOL exchange. She actually had a toric lens and refractively was found to really be better off with a non-toric, so her lens was going to be exchanged. The reason I'm sharing this video is to share with you my experience that there is no such thing as a routine exchange. And as you'll see, as I do the case, that this case goes from a routine to a complicated case. So I'm using a diamond blade to enter my pre-existing paracentesis incision, and then I go in with a cannula and able to bluntly open up that paracentesis incision. I'm injecting some intracameral lidocaine. On the other side, I'm using a needle to penetrate through that paracentesis incision, and then I'm going straight with the needle that's already mounted on some dispersive viscoelastic, going underneath the capsular rhexis edge, and I'm injecting that dispersive viscoelastic. I'm trying to get the anterior capsule separated from the lens, and then trying to go beyond the lens edge and separating the anterior capsule from the posterior capsule. So I'm going around on the other side and doing the same thing. I'm just gently trying to go in, again, using the needle, going underneath the anterior capsular rhexis edge and trying to push that dispersive viscoelastic into the capsular fornix and pushing and separating the anterior and posterior capsules. Go ahead with my temporal keratoma incision. I'm injecting some more viscoelastic to clear all the bubbles, and then I'm going to go under the right side capsular rhexis edge, and then I'm going to push some viscoelastic into the capsular bag. You can see a little wave of viscoelastic coming from the right to the left side. Once I've filled the bag, I'm decompressing the bag with the cannula. And I want you to pay attention to the capsular bag, the posterior capsule on the left side. See right there? Do you see that movement? It's on the left side of the lens optic. You can see there's a posterior movement. And now you can see there is a posterior capsular tear. As you can see, it's a vertical line, and you can see viscoelastic going beyond that posterior capsule tear. So let's look at it again in real time. I'm pushing the viscoelastic from the right side. You can see the wave going towards the left side, and then I'm decompressing the bag. And so everything looks fine right now. I'm sitting here just staring at it. Actually, I'm getting my Sinskey ready, and so I only noticed this afterward. But you can see it almost like an apparition, like a ghost just comes and rips the posterior capsule. You can see that tearing of the posterior capsule and the split occurring, and now you can see the movement of the viscoelastic beyond the rent. I was both furious and flabbergasted at the same time. I went back to look at this video, and I could just sit here staring at that posterior capsule, which was intact, and just see that posterior capsule rent just slowly appear before my eyes, almost like a ghost. Was just, I've never experienced that before. So at this point, I have to refocus and remove this lens. And so I'm going to use my Sinskey hook. I'm starting inferiorly first, and then I'm going to start with the distal side. I'm getting around the optic as well as the haptic, and I'm pulling the haptic up. You can see it's somewhat free, and I'm able to tease that distal haptic up into the anterior chamber. And I try to do the same thing, pulling on the optic haptic junction. I was able to get the proximal haptic up quite easily as well. I have a scissor and forceps now. I'm using the scissor to tease the optic up towards the teeth of the forceps, and then I go ahead and start cutting the lens in half, holding the lens with the forceps in my left hand, and I'm bisecting it completely. While I'm still holding the lens with my forceps in my left hand, I'm going to position the haptic out of the eye with my other forceps. As I grab the optic, I saw that the haptic slipped back in, so I go back and grasp the haptic again. And then I'm going to try to reposition and grasp the optic. It would have been better if I did a two-handed maneuver here, because I struggled a little bit. If I grasped it with the forceps in my left hand first, I could have positioned the lens optic in my right hand more easily, just like I did there. And so I go ahead and do that here. I grasp the lens with my left hand first, and then I'm able to position the teeth of the right hand forceps to grasp the optic. It slipped out of my grasp, and so I'm using the other forceps to help me pull that lens out. So once the lens is removed, what do? I'm going to try to preserve the bag as much as possible, and I decided to do a reverse optic capture with a single piece acrylic lens. So this patient still had a refractive demand that she was wanting to have a good uncorrected vision, and so that was the point of the IOL exchange. And so that's why I chose to go with a single piece acrylic lens with reverse optic capture, because I know it would give me the best and most consistent refractive outcome. So the lens is delivered into the bag. The haptics are unfolding very nicely and slowly. I'm using the cannula to position both haptics within the bag. And again, I have a rent there, but I'm making sure that the haptics are not in the area of the rent. And then I'm going to go underneath the optic with the cannula, and I'm going to reverse optic capture it right here. So I'm able to position it, lift the optic up out of the bag, and now it's captured within the capsular rhexis. And this is an important pearl. In this situation, you always want to keep the IOP low. When you go in, you might push a lot of pressure and then blow that optic back into the bag. You don't want to do that. You want to keep that reverse optic capture configuration. So before I started with the INA, I went to the low IOP setting. Instead of 50 or 60, it's down to 30. And you'll be able to carefully and easily remove the viscoelastic from the anterior chamber while maintaining that reverse optic capture configuration. Now you can clearly visualize the rent, the vertical rent, now that the lens is in there. What is the learning point in this case? And that is this: every IOL exchange is a potential complication or risk. The posterior capsule is not like a virgin posterior capsule when you do cataract surgery. When you do cataract surgery, the posterior capsule is quite elastic and it's quite forgiving. And so when you're injecting the bag with the Provisc, it's very forgiving. In this case, I injected viscoelastic in a bag, but also the lens was still in place. So what it did was cause a posterior capsule blowout. Even though there wasn't a huge amount of pressure on the posterior capsule, you can see any little bit of pressure, even from that viscoelastic, just a little bit of tension caused that posterior capsule to split. And it was very sensitive. So again, that's the moral of the story. The posterior capsule outside of the original cataract surgery is very delicate, and you want to handle it with a lot of care, and don't put a lot of pressure on the posterior capsule. Try to prolapse that lens out early out of the bag so that you can minimize your risk to the capsule. So beyond the nuances of doing an IOL exchange, getting the anterior capsule free from the lens, dissecting between the anterior capsule and posterior capsule into the capsular fornix, freeing up the lens, cutting the lens, removing the lens. The most important part, after you do all of those techniques successfully, if you're not careful with the posterior capsule, you can develop a posterior capsule tear even with a minimal amount of stress. So I hope this was helpful to you. Please like and subscribe, and I thank you for your attention.